In the female genital system, we do have external genitalia. We refer to all these structures as vulva. We have vagina. I'm pointing at the vaginal canal. Recall, this is the place that sperm and semen will be ejaculated into. When I follow vagina, then I get to uterus, this bulky organ that sits between rectum and urinary bladder. And when I look at the lateral side of the uterus, I see ovary and fallopian tube. Please keep in mind, I'm pointing at the right ovary and right fallopian tube. We have two of each one of these organs. And I notice both ovary and fallopian tube are connected to the lateral side of the uterus. There is a ligament that we name it ovarian ligament that connects ovary to the side of the uterus, and fallopian tube on its own is attached to the uterus. We have several supporting structures that hold these organs in place. For example, I would like you to pay attention to this very large ligament that is called broad ligament. This is a ligament that holds uterus and attach it to the lateral side of the pelvic region. Also, broad ligament has a significant role in holding ovary and fallopian tube in their positions. We also can find a small part of another ligament that is called uterosacral ligament. We have two uterosacral ligaments. Obviously, this is the right one. When we follow this ligament, it goes lateral to the rectum, and the other end is attached to the bone sacrum. So we can say that uterosacral ligament attaches uterus to the sacrum. Here I can see another ligament that is called round ligament. This is the one that attaches uterus to part of external genitalia that is referred to as labia majora. So there are multiple supporting structures that hold these organs in place. Even though these ligaments hold uterus in place, they allow a little bit flexibility and movement to uterus. For example, sometimes uterus tilt a little bit backward. We call that retroflexion. Retroflexion in general is harmless. It could happen after childbirth, or sometimes we don't know exactly what the cause is. However, it is dangerous if those ligaments are so weak that uterus start tilting downward. We call this uterine prolapse, and it could be due to the weakening of the ligaments, which we can see some of those ligaments in this model, or weakening of the pelvic muscles be due to aging. Some diseases or traumatic vaginal delivery could actually lead to downward tilting of the uterus, or chronic straining from coughing or difficult bowel movement, or some pelvic tumors can actually push uterus down. We have 3 degrees of uterine prolapse. Please keep in mind the lower part of the uterus, the part that I'm pointing at right now, is called cervix. In the first degree of uterine prolapse, cervix, which is supposed to be above vagina, actually moves downward. Basically, cervix is now inside vagina. In the second degree of uterine prolapse, we see that cervix is out of vaginal canal. Basically, cervix is completely outside the body. And in the third degree of uterine prolapse, which is referred to as complete uterine prolapse, the entire uterus is outside of vagina. Clearly, that's a very severe case. Depending on what is the cause of uterine prolapse, we come up with a variety of treatment plans that include, for example, pelvic exercises. If the patient is overweight, we might put the patient on some diets to lower the weight. Some patients might need stool softener to minimize the straining that uterus experiences during defecation. So now it becomes clear why we have to pay attention to the location of uterus compared to the location of rectum. Also, in some patients, we might need to place some rubber devices to hold cervix in its place, or in severe cases, clearly we need surgery. So this was a very short example to emphasize the importance of learning about the supporting structures such as the ligaments, and also the importance of having enough amount of fat tissue in the area. Now I move on to focus on each one of these organs one by one, and I would like to start with the ovary. Each ovary is the size of an almond. This is the gland of female genital system, and many important things are going on inside the ovary. I just talk about a few of them. For example, inside the ovary, we have the process of oogenesis. Oogenesis refers to the process of forming cells named oocyte. And also from ovaries, we have release of major female sex hormones such as progesterone, estrogen, relaxin, and inhibin. When the time comes that ovary releases the oocyte out, which we refer to this process as ovulation, that would be the moment that luteinizing hormone, which is released from anterior pituitary, stimulate the ovary to push the oocyte into the pelvic cavity. Even though in the model it looked like that fallopian tube and ovary are attached together, let's make it clear that between fallopian tube and ovary, we have a space filled with interstitial fluid. So when ovary releases the oocyte out into the pelvic cavity, we expect fallopian tube to do something and pull the oocyte in, simply because this is the place that we expect sperm to meet the oocyte, to fertilize the oocyte. When we follow the anatomy of fallopian tube, we see that the part that sits next to the ovary has a funnel shape. We name this infundibulum of the uterine tube, or infundibulum of fallopian tube. And we notice that infundibulum has some finger-like projections. We name these finger-like projections fimbriae. The lateral 2/3 of fallopian tube is wide, and obviously this is the longest part of the fallopian tube. We name this ampulla of fallopian tube. This is the preferred location for fertilization of oocyte. When we move toward the uterus, we see that fallopian tube becomes narrow. We name the medial 1/3 of fallopian tube, the narrow section, isthmus of fallopian tube. The lining of fallopian tube, as we know, is ciliated simple columnar epithelium. Recall, cilia always move things. And in the wall of fallopian tube, we have smooth muscles. So let's clarify. When ovulation takes place and ovary releases oocyte into the pelvic cavity, during that time frame, we notice the motion, the movement of fimbriae changes to create some waves and pull the interstitial fluid that contains oocyte in. And the cilia that we have in the lining of fallopian tube and the smooth muscle contraction all help oocyte to move toward the uterus. Please keep in mind, if oocyte become fertilized, which the result of union of an ovum and sperm would be a cell named zygote, zygote is going to multiply pretty soon, go through mitosis, so we end up with more cells, and eventually at some point, this group of cells form a structure named blastocyst. And blastocyst has to go through implantation. It has to get inside the wall of uterus, simply because this is the preferred location to grow an embryo and later a fetus. And especially the back wall of the uterus, the wall that gets support from the vertebral column, is the preferred location for implantation of the blastocyst. So it is crucial that the cilia and also the smooth muscle contraction not be interrupted, their actions, and they move the oocyte or the fertilized ovum toward the uterus. The timing has to be perfect, simply because any chemical or substances that paralyzes cilia or doesn't let the smooth muscle contraction to happen in the wall of fallopian tube can easily increase the risk of ectopic pregnancy. When we say ectopic pregnancy, it simply means that implantation of blastocyst happens somewhere not in the wall of uterus. For example, the blastocyst might eventually start penetrating into the wall of fallopian tube, which clearly this is not a place to grow an embryo, and that could easily cause the rupture of fallopian tube if we do not really take care of this situation immediately. Or if the fimbriae do not have those unique motions at the time of ovulation, and if the oocyte stays in pelvic cavity, it is possible that fertilization happens inside pelvic cavity, which clearly we know this is not, again, the place to grow a fetus. So now when I follow the fallopian tube and successfully get to the uterus, I focus on the location of the uterus. This is the organ that sits between rectum and urinary bladder. There is a layer of peritoneum, as you see, covering the uterus, and that layer also covers the superior part of the urinary bladder. Between urinary bladder and uterus, we have a pouch. We name this vesicouterine pouch. We also have a pouch here between uterus and rectum. We name this one rectouterine pouch. The size of a uterus in a female that never been pregnant is smaller than a female that recently has been pregnant. In female that never experienced pregnancy, the length of uterus is usually around 7.5 centimeter. The width of the uterus is about 5 centimeter and the thickness is about 2.5 centimeter. Please keep in mind, after menopause, due to low level of female sex hormones, recall they're released from ovaries, we have atrophy of the uterus. Uterus gets smaller. In the uterus, we have a dome-shaped area. We call this fundus of the uterus. The middle part, which is the largest part, is the body of the uterus. And the lower part is cervix. The space that we have here is referred to as uterine cavity. The space that we have in cervix is referred to as cervical canal. The opening that we have right here, the opening that connects uterine cavity to cervical canal, is called internal os. The opening of cervical canal to vaginal canal, that opening is called external os. So if I go through this, here we have uterine cavity, internal os, cervical canal, external os. As you see, the body of the uterus is moving anteriorly and superiorly, but the cervix is sitting inferiorly and posteriorly. So this is a unique position that body and cervix have. And then in the wall of uterus, we should identify 3 layers. 1, 2, 3. The outer layer, which is part of peritoneum, is called perimetrium. The middle layer is called myometrium because it's formed by 3 layers of smooth muscles. And as you notice, the thickest myometrium is in fundus, the thinnest myometrium is in cervix. And the inner layer is called endometrium. Endometrium is highly vascularized. The artery that I'm pointing at is internal iliac artery. From internal iliac artery, we get some branches named uterine arteries. They are supplying the different layers that we have in the wall of uterus. Back to the myometrium, we know that sometimes we expect myometrium to stay relaxed. For example, during the time that we expect implantation of blastocyst, which would be after the ovulation, we would like these muscles to stay relaxed and increase the success of implantation. And relaxation of these muscles is due to the hormone relaxin that is released from ovaries. But when it comes to childbirth, we want myometrium to contract and push fetus out. And we know at that time, we rely on oxytocin hormone, which is released from posterior pituitary and travels through bloodstream, gets here and stimulate muscle contraction in the myometrium. In endometrium, the highly vascularized inner layer, we should identify 3 sections. We have compact layer, below compact layer, we have functional layer, and deep to functional layer, we have basal layer. Compact layer and functional layer are the 2 layers that we lose during menstruation. And when we know that endometrium is highly vascularized, is full of blood vessels, it makes sense when menstruation happens, which is due to very low amount of estrogen and progesterone released from ovaries, we find blood components in menstrual flow. And obviously menstrual flow exits the body through vaginal canal. So the end of vaginal canal, this opening, which is referred to as vaginal orifice, should be open. After losing compact layer and functional layer, and after the menstruation ends, we rely on basal layer to build compact and functional layer again. And the reason that basal layer is so successful in rebuilding functional and compact layers is because in basal layer we can find lots of stem cells. Recall, stem cells are undifferentiated cells that have potential to become a variety of cells. So having lots of blood supply and containing the stem cells make basal layer successful in rebuilding functional and compact layers. And please keep in mind, hormones such as estrogens and progesterone released from ovaries stimulate the basal layer to rebuild functional and compact layers and add to the thickness of endometrium. So we are ready again for a possible implantation in the near future. When I get into the lining of cervical canal, here we have some glands that they secrete cervical mucus, which clearly cervical mucus is a mix of water, glycoproteins, lipids, enzymes, some inorganic salts. And the secretion of cervical mucus varies during a female cycle. Please keep in mind, during reproductive life of female, which is from puberty to menopause, each cycle takes about 28 days. During these 28 days, there are days that the female genital system is hospitable to sperm. And to explain that, we can focus on the cervical mucus. On daily basis, in a female, we have secretion of 20 to 60 milliliter of cervical mucus. Around the time of ovulation, the time that ovary ejects the oocyte into the pelvic cavity, because ovary is stimulated by luteinizing hormone, around that time, we see that the cervical mucus becomes thinner, less viscous, and its pH rises to an alkaline pH, around 8.5. And clearly, a thinner cervical mucus that has an alkaline pH allows sperm to get in. And also, the cervical mucus protects sperm from phagocytes that we have in the female genital tract. Please keep in mind, sperms are considered invaders in the eyes of the immune system of the female. So that would be one of the roles of cervical mucus, to protect the sperms from the immune system of the female. Also, the cervical mucus nourishes the sperm, and it's been shown that the cervical mucus might have a role in the functional changes that sperm must go through in the female genital tract to be ready to fertilize an oocyte. For example, the tail of the sperm should start having a more rigorous movement, and the plasma membrane of the sperm should become ready to unite with the plasma membrane of the oocyte. So that would be the role of the cervical mucus. And please keep in mind, when the cervical mucus become alkaline, it also a little bit act as a buffer to neutralize the pH inside the vaginal canal, because in the vaginal canal, the pH is acidic. However, when it's not during the time frame of ovulation, we notice that the cervical mucus becomes thicker, more viscous, and its pH start dropping. So it becomes less hospitable to sperm, and also makes it more difficult for sperm to get in. After cervix, I move into vaginal canal. First thing that I notice is between cervix and vagina, we have this indentation or depression, if you like to call it, that we call this vernix. For example, in those females that a contraceptive diaphragm is placed, if it's placed correctly, it has to be placed inside the vernix, and the diaphragm is going to close off the cervix and doesn't let the sperms to get inside the cervical canal and uterine cavity. When from vernix I start moving down, and then I see that vaginal canal is narrow, and when we get close to the vaginal orifice, it becomes wider. In the lining of vaginal canal, we have rugae, those elevations that we see in the image. And then when we get very close to vaginal orifice, we see that a thin layer of mucous membrane, which is vascularized, is found at the border of the vaginal orifice. This layer of mucous membrane that we find around the opening of vagina into the exterior is called hymen. In most cases, hymen partially encircles the vaginal orifice, but sometimes it happens in some females that hymen completely closes off the vaginal orifice. If that's the case, which the condition is called imperforate hymen, in most cases an operation is necessary to open up the hymen and open up the vaginal canal to the exterior and allow the menstrual flow to exit. In the lining of vaginal canal, we have a large amount of stored glycogen, and recall that when glycogen goes through decomposition, acidic substances are produced. That explains why the pH inside the vaginal canal is acidic, which actually that's an advantage for female, because acidity makes it more difficult for microbes to grow here and cause infection. However, we know that this acidity is harmful to the sperm. That's why it is very important that in male genital system we have glands such as seminal glands and bulbourethral glands that secrete buffer as a component of semen. So the buffers that we find in semen neutralize the pH inside the vaginal canal and increase the chance of surviving of sperms here. Plus, we know that if we are around the time of ovulation, the alkaline cervical mucus also helps neutralizing the pH inside the vaginal canal. After learning about vagina, now it's time to learn about the external genitalia of female, which is called vulva. I start with this anterior elevation that is covered by skin and pubic hair, and it's named mons pubis. As you see, there is a large amount of adipose tissue in the mons pubis. Please keep in mind that's pubic symphysis. That's the joint between the two hip bones that meet anteriorly. This blue structure represents the fibrocartilage that holds the two hip bones anteriorly together. And we know that having so much adipose tissue in a structure such as mons pubis has many advantages. One would be fat is a great cushion. It absorbs shock and trauma and protects these delicate organs that we have here. And please note that at some point there is a possibility of growing a fetus in this area. Also, we know that in adipose tissue, the adipocytes, the cells, store triglyceride, which is a source of nutrient. And last but not least, we know that fat tissue helps holding these organs in their place firmly. So that helps stabilizing the organs in their position. From mons pubis, when I continue and move posteriorly, I can find two longitudinal folds that in this model, I see just one of them. These two would be referred to as labia majora. That would be the right one. The two labia majora are also covered by skin and pubic hair. And in the labia majora, we can find also some apocrine sweat glands, some sebaceous glands. Medial to labia majora, we find labia minora. This would be the right labia minus. So imagine that we have also a left labium minus. Also is covered by skin, but the difference is that we do not have pubic hair covering the labia minora. And the other difference is that when we get to the two labia minora, we notice that the number of sebaceous gland increases significantly. So basically, labia minora have more sebaceous glands compared to labia majora. We know that sebaceous glands secrete sebum, and in the secretion such as sebum, we find antibacterial substances. So if you think about it, there are two strategies to protect this region of female body from microbes. One would be the antibacterial properties that we find in the secretion of sebaceous glands, and the other one would be the acidity of vaginal fluid. We do have sebaceous glands also in labia majora, but not to the extent that we find in labia minora. When we follow the labia minora, both of them, exactly where they meet anteriorly, we should locate this cylindrical structure that is called clitoris. Inside clitoris, we find two erectile bodies, two corpora cavernosa. We find nerves, blood vessels, and upon tactile stimulation, enlargement of clitoris happens, and that plays a role in sexual excitement of female. Exactly anterior to clitoris, we have a layer of skin that would be called prepuce of clitoris. The section of clitoris that is visible, we call that glans clitoris. So now if I try to visualize the left labium minus exactly between the two labia minora, I have a space. We refer to this space as vestibule. Inside the vestibule, posteriorly, we find the vaginal orifice. From vaginal orifice, when I move anteriorly, I find external urethral orifice. That's the pathway for urine to be excreted out of the body. And from external urethral orifice, when I move anteriorly, I find glans clitoris. So those are three important structures that we find in the vestibule. And last but not least, I would like to emphasize flexibility of pubic symphysis in female is impacted by the release of the hormone relaxin. Recall that relaxin is one of the 4 groups of hormones released from ovaries. When the secretion of relaxin increases, we see a slight change in the flexibility of pubic symphysis. And please note, when this joint becomes more flexible, it allows the expansion of organs here. So basically, the female genital system prepares itself for pregnancy. Also, if pregnancy happens later, we know a structure named placenta forms. From placenta, we also have secretion of relaxin. And we notice that throughout the stages of pregnancy, the flexibility of pubic symphysis increases. And also the relaxin that is released from placenta helps dilating the cervical canal when we get close to the time of childbirth. So in general, we can say that many of the activities that happens in the female genital system would be regulated by hormones. And it's important to note that 4 of those female sex hormones are released from these tiny glands. Right now, I'm pointing at the right ovary. And in a separate video, I'm going to explain the process of oogenesis and the secretion of those hormones from ovaries. Hope you find this helpful.